Assalamu alaikum. Good afternoon, everybody. Thank you for joining us for part 2 of this QU Health CPD webinar series. We're very happy to welcome you to part 2 of this series. Thank you so much for sharing your feedback after the first webinar last week. We're looking forward to more of your insights this week. So please do use the chat throughout today's webinar to share your questions and comments and experiences with the live panel. Before we start today's webinar, I'd like to say a big thank you to our contributors. We've worked with stakeholders across Qatar to make sure we have the most the insights that will benefit you most and will be able to contribute towards today's discussions. Shortly, I'll be introducing you to today's panelists, but before we start, just a few housekeeping. So this is part of a 5-part webinar series. So this is part 2. Each week we'll be delivering a different aspects of autism spectrum disorder. Today the webinar is starting at 1 p.m, but from next week onwards, the webinars are scheduled every Wednesday from 12 until 1 p.m. So we look forward to meeting you at the future webinars. So today's webinar is focused on autism spectrum disorder and co-occurring conditions. Okay, so these are the 5-part series. So next week we'll be introducing you to evidence-based interdisciplinary care, and we have a subsequent two further workshops after that. So as I mentioned, today's webinar is focused on autism spectrum disorder and co-occurring conditions, and we have our experts joining us from Hamad Medical Corporation and Sidra Medicine. Before we start today's webinar, I'd like to confirm with you that the presenting authors and scientific planning committee members have no relationships and no conflicts of interest to disclose. And the learning outcomes for today's webinar, we want to discuss examples of common comorbidities and conditions associated with autism spectrum disorder, distinguish between ASD and other co-occurring neurodevelopmental disorders, and discuss the challenges of diagnosing and treating comorbidities in individuals with autism. So the way that we set out the series, we have a panel discussion. So each of our panelists will be delivering a 5 to 6 minute presentation. We'll then be inviting some questions from the audience that we will be putting to our speakers. And then at the end, we hopefully have 15-20 minutes to take more questions from the audience. We have made a note of the questions that we didn't manage to cover in last week's webinar, and we'll be also putting those to our speakers where they are relevant. So please, from the outset, I want to let you know regarding the CPD, your CPD certificates. So as you know, DHP, they've recently adopted a new method for claiming CPD points. We'll be taking your attendance from the post-activity survey. So in order for you to claim your CPD points today, you'll need to complete the survey, which will be shared with you at the end of the webinar. And then we'll be sharing we'll be taking your license number and QID and sharing that with DHP in the coming days. So you will need to complete the survey in order to be eligible for the CPD points. Please just make sure that you're putting your Qatari ID and your license number in correctly. Your license number, you will need to include the first letter in the license number. So throughout today's webinar, we encourage your interaction. Please use the chat to jot down your questions. It's not necessary to put your name and credentials in the chat. Please try to reserve the chat for your questions. Joining us today as well, we have Dr. Shahad Al-Amin, and she'll be moderating today's discussions and also taking your questions and putting them to the speakers. So Dr. Shahad, would you like to introduce today's speakers, please?
Thank you so much, Dr. Zak, for this introduction. Really, we're all in for such an interesting topic today, such a challenging one as well. Personally, I'm really eager to hear about the co-occurring conditions and how we can look for them and differentiate between them. Today, our speakers are both from Sidra and Hamad Medical Hospital. Perhaps without further ado, we could start with our first speaker, Dr. Madiha Kamal.
Hello, Shahad. Thank you for inviting me to this conference, to this workshop. Shahad, you have the slides. You are moderating the slides.
Yes.
I have nothing to disclose. And if you go to the third slide, I just want to repeat what we have said already in the previous session, that ASD, Autism Spectrum Disorder, is a neurodevelopmental disorder characterized by persistent deficit in social and communication, also restricted repetitive pattern of behavior and interest. And the next slide, slide 4, is simply going to show you that the real problem with autism is the social functioning is one of the core deficits. So it's not really necessary that every child on the spectrum has intellectual disability, and this is the common misunderstanding from a lot of personnel in the community. And they worry about intellectual disability. We'll come to this at the end. But the main issue is really the communication problem. The next slide, Shahad, slide number 5. I'm just going to repeat the DSM-5 criteria for ASD. Social deficit in the social communication and social interaction. You need to meet 3 of the 3 in the first category and 2 of the 4 in the second category to make the diagnosis. Social emotional reciprocity meaning back and forth conversation. The verbal and the nonverbal communication can be affected, the eye contact, responding, not responding to name, and the relationship's ability to make friends is limited. And again, I'm going to repeat what I said last time, ability to make friends, it's not very obvious in the first few years of life. However, it's more in the middle school and the high school. The second group is the repetitive restrictive behavior, so repetitive speech or excessive adherence to routine. They like to follow the same routine. Restricted fixated interest, as in interested in dinosaurs, interested in certain things in World War II. I had patients interested in that. I had patients interested in planes, in trains, and it's a lot of things. And sensory issues, whether auditory, sensory, certain noises bothers their ears, or visual or tactile. Next slide will show us that there's difference in terms of the severity. There's a level 1, 2, or 3, which is the most difficult, level 3. And the next slide will show the problem really is behavioral, developmental, and educational issues. The goal of therapy, when we talk about management, we talk about maximizing their functioning, moving the child to being independent, and this is very important for the families, and improving the quality of life. The goals of therapy is really, I have to emphasize how important the parent and the family involvement is very important, and very effective training the parents in these situations. The slide after it emphasizes on how important to target specific behaviors at the time, which is the sleep is the most common problems I hear from parents, that the child is not sleeping well, and failure to initiate social interaction and self-injuries. Again, I always tell the parents in the next slide, it's Shahad, if you move on to the next slide, parents ask me, is it important to have the diagnosis? I'm investing a lot of money in the making the diagnosis. I tell them the most important is really start investing your time and money with communication and speech, because this is the number 1 thing you want to learn earlier on. Next slide, Shahad. Just quick tips we would like to offer the parents is that criticize gently, offer choices when you can, for these patients to reduce their anger, because this is the one thing that a lot of parents complain of, is that anger issues that they could exhibit. The next slide, it's interesting how a lot of pediatricians ask me, Doctora, I have a 5-year-old and I'm not sure if this is autism or not, but I tell them that some cases are getting diagnosed later in life. That doesn't mean they didn't have it. It just the social situation made it obvious when the demand is higher, so later in life. And these are the higher functioning children with autism. And some of them, they tend to lose the diagnosis if they did a good early intervention. So the next slide is what we want to focus on in this presentation, is that what comorbidities, what other things that could come, and Dr. Ali will emphasize more, will expand on this. Some children with autism, they do have intellectual impairment. Something like 30 to 40% of children, not all of them have intellectual disability. Language impairment is one of the main issues, and that's what I tell parents: you have to start intervention early on. Some of them can have genetic disorders or environmental problems and associated with other neurodevelopmental disorders. And the last slide is the comorbidities that we have is an anxiety. Children with autism can develop an anxiety, and it's very tricky to find out that this is a behavior because of an anxiety. And anxiety can happen whether early in life or in the middle school, which is the teenagers. Teenagers can have an anxiety because they know that they cannot make friends, they don't have friends. And also they develop an anxiety from new places, from new environment, from making friends itself give them some anxiety. Depression, yes, some of them, they do develop depression. Again, especially in the teenage group, they know that they are different and they know that people are treating them differently. They could be bullied. They could be bullied due to lack of skills, lack of social skills. They could be very smart, but not able to implement their higher cognitive abilities. Some of them, they struggle with developing a good social skills, and this is how they develop depression and anxiety. Some of them have hyperactivity, impulsivity, some of them Tourette, some would have epilepsy. The chances of a child on the spectrum to have seizure disorder is higher than average children. It's probably 20% higher than the average child. And the last thing I want to say is psychotic symptoms. So I'm going to leave the floor to Dr. Alia, and she will expand on a lot of what we said. Thank you.
Thank you so much, Dr. Madiha, for your comprehensive and insightful presentation. Perhaps we can move on with the next presentation, and then we will answer all of the relevant questions after Dr. Alia's part, inshallah. Just to introduce Dr. Alia, Dr. Alia Sati is the clinical lead for developmental pediatric service and senior attending physician in rehabilitation medicine and developmental pediatrics division at Sidra Medicine. Prior to joining Sidra, she was the clinical lead for pediatrics, neurodisability, and epilepsy services at Salford Royal NHS Foundation Trust in the UK. She has over 15 years experience in the NHS UK, and right now she is the Associate Program Director for Qatar National Developmental Peds Fellowship Program. Dr. Alia, the stage is yours.
Assalamu alaikum, everyone. Can you hear me, Jahad, and everyone?
Yes, we can hear you all.
Okay. Well, thank you so much for inviting me. It's an honor and my pleasure to reach to such a large audience through Qatar University. So I have no relationships or conflict of interest to disclose. My dear colleague, Dr. Madiha, set the scene nicely to describe what is autism and the associated comorbidities with autism. So I will take a slightly different approach and talk more about how to differentiate between autism and other neurodevelopmental disorders. So some children or individuals may have autism and other comorbidities, and others may have no autism and they have other neurodevelopmental disorders. So I like this quote that beyond conformity, the world needs diversity. We're all diverse. The world needs us to be diverse to be able to serve humanity. However, at times, although diversity can come with may or may not come with some talents and skills, special skills, but more than often it comes with some challenges. So neurodiversity, there are so many conditions, and this is not an exhaustive list. But the most common are autism spectrum disorder, intellectual disabilities, learning disorders, ADHD, language disorders, and so on. So it's an art and a skill to differentiate between all. And the diagnostic odyssey can be quite a long journey, can be a challenging one in some individuals to reach the correct diagnosis of area of difficulty. In some, it's easy, it's straightforward, difficulties are clear, but in others, it can be quite complex. And for this, an appropriately qualified clinician or professional is needed. And why I'm saying your child, because one, because I'm a pediatrician, and two, because neurodevelopmental disorders should have started in childhood. Unlike, for example, mental health disorders that may start in adulthood, neurodevelopmental disorders should have started in childhood. Yes, severity, and when it becomes obvious, as same as my colleague said, it depends on the demand of the time. The less severe, sometimes the later diagnosis. What helps us to diagnose is that there are objective international standards and classifications for each condition. One example is ADOS. It's a standardized assessment for autism that needs special certification. There are some IQ tests, for example. So most conditions have some standardized scales that specific professionals have the skill to assess for. So how we try to make our life easier to think and filter down the issues is we think of the domains of development, such as gross motor skills, fine motor, communication, cognitive, social, adaptive skills. I will also add behavior and academic achievement. And the last two are not actually domains, but they are kind of outcome of these domains. And depends on where, what we try to do is map the child or in the individual's skills, strength and weakness. For example, one child may be extremely smart. They may have a very high IQ, but they have extremely poor social skills. And likewise with other skills, they can be very variable. And that's how we try to differentiate between each condition and the other. Why is it important to diagnose or to give a condition a name? Is first of all, when you give something a name, then you know how to search for solutions or support. And I'll give some examples. If the main area of difficulty is social communication, then we're thinking more towards autism. If it's mostly cognitive skills or IQ, we're thinking more towards intellectual disabilities. Gross motor skills could be cerebral palsy. Behavioral, it's, I would think more ADHD. Again, when say behavioral, it can come in all conditions. It can be a result of many conditions. So my colleague, Dr. Madiha, presented nicely all the criteria of autism. And I have to say, the number one may be easy to figure out. Lots of parents come with this concern that there are issues with social skills or communication. However, when it comes to the restricted repetitive patterns of behavior, in some children it's quite straightforward. For example, they have intense interest in planets and flags and countries and dinosaurs, or they have very clear sensory differences. In some children, I would say mostly the mild, moderately affected children with autism, it needs some digging. So we need to ask so many questions. We need to spend a long time with the child. We may need to administer some standardized skills. It may not be as easy to diagnose, and also for parents, because the common knowledge with autism is mostly to do with severely autistic children. When it comes to moderate or mild, more so with mild, lots of parents will be shocked that the child has autism because they say, oh, well, my child has some eye contact. My child is clever academically. My child is interested in people. But yes, that doesn't exclude the diagnosis of autism because there are different levels of every skill. So ADHD, and I have to say this may be where most of the confusion is between autism and ADHD, because lots of children with autism are hyperactive. Obviously not all, but some are hyperactive, and inattentive may also be impulsive. However, it's easy to see and describe hyperactivity. However, when it comes to inattention and impulsivity, it's very tricky to differentiate between the social inattention. So when the child has limited joint attention, that they don't pay attention to people. They're not paying attention to individuals around them. Whilst in ADHD, it's more of distractibility. They are attending to people, but they struggle to focus. So this is not easy to differentiate sometimes. Same applies to impulsivity. In autism, children may be self-directed, meaning they want to do what they want to do. It's not easy to guide them. Whilst in ADHD, impulsivity is more of, I can't wait, I need this now. So again, it's not easy to differentiate. Certainly, autism and ADHD can co-occur, but not all children with autism who are hyperactive have ADHD. But that doesn't stop people from treating them or a trial of medications of ADHD. But it's not an easy diagnosis to make in children with autism, to have an additional diagnosis of ADHD. Whether it's just autism or just ADHD, this relies mostly on their social skills. So the focus will be social skills. We think their social skills are appropriate for age, or there are just some subtle difficulties, but on the whole, they're functioning well on this and at the social level, then that's mostly ADHD. If social skills are the predominant problem, but they are hyperactive, this is autism. Back to the criteria of ADHD, symptoms should be present in more than one setting. It should affect functioning. So a hyperactive child who's fidgeting and hyperactive, but functioning absolutely fine. They're achieving in school, they're paying attention. Behavior is, yes, they fidget, but at the same time, it's not negative in any way. This may not be ADHD because it's not affecting them functionally. Symptoms have to be also present from early childhood. And the last one, I would say, is the most important. Symptoms are not better explained by other disorders. Again, because it could be only autism with some hyperactivity. I will go back to this slide. And the last point is these disturbances, we're talking about autism here, are not better explained by intellectual disability. Again, this is another tricky area where we have to differentiate between only intellectual disability or intellectual disability and autism. For this, I remember whilst I was in training in the UK, I remember a psychiatrist I work with used to say to me, try cognitive referencing, meaning, and I'll give an example here. Imagine a child who's 10 years old, whose IQ is more like a 5 years old. If their social skills are actually like a 5 years old, matching their cognitive level, this may just be intellectual disability only. However, if it's more like a 2-year-old, so way less than their 5 years old cognitive level, this is autism. It's not easy, but it can be diagnosed accurately. I think I spent well more than 5 minutes. I'll try to speed up. There are only 2 more slides. Intellectual disability affects intellectual functioning, so we need an IQ test. It also affects adaptive functioning, so their daily living skills. So as I said, if social skills are similar to their IQ level, that's just intellectual disability. The last slide, specific learning disorders or learning disabilities such as dyslexia, dyscalculia, dysgraphia, Sometimes people use it interchangeably with intellectual disability, and this is very inaccurate because they're very different. Intellectual disability individuals have low IQ, whilst learning disorders, learning disabilities, children or individuals have average or above or below, just below, low average, let's say. It's not below, but it's low average. IQ is not the problem because outside academics, they're functioning absolutely fine. But when it comes to academics and the decoding of letters and numbers and letters, that's where the problem is. Hence, it's a learning disability. And there are specific tests for this as well to differentiate between the two. This is a reference, and the main book here that we use is the DSM-5 for criteria.
Thank you so much, Dr. Alia. There is a lot of questions coming through from our audience. One of the questions, maybe we'll start with this one. Can you elaborate on the link between ASD and depression and anxiety, please?
The link between ASD and depression and anxiety is that the children on the spectrum, especially the higher functioning, they could easily detect that, they could understand that they're being treated differently. Some of them gets bullied due to their social skills, and this is how they feel sad at the end of the day. But also some of them feel anxious, and some of the anxiety, I have to say, it does start early in life. Some of the 5-year-old, 6-year-old, 7-year-old have an anxiety because they have rigidity in their routine, and new places is always difficult for them. So suddenly the routine is to go to the school every morning, and suddenly they're sitting in a doctor's office, for example, without previous explanation. So this can cause an anxiety for children on the spectrum. So anxiety can happen at any age, and certainly the depression can happen in the late childhood, early teenagers.
Thank you so much. The next question is, so what's the impact of delayed diagnosis of ADHD and other comorbidities? So I think maybe this is relevant to your presentation as well.
This is Dr. Mediha speaking. So when we talk about ADHD impairment, I mean, if Dr. Ali would allow me to answer this. So ADHD the question, where's the impairment? If there's an impairment, whether it's academic or social, then you are impairing this child to progress. If the child is failing school because of inattentiveness and you're delaying the management, then definitely the child will end up, will be difficult to catch up later on. So this is the question, where is the impairment of ADHD? If there's no impairment and you didn't diagnose a child with ADHD and you wait until 20, that's fine. But if there's an impairment and the child is failing grade 1, 2, 3, 4, then you need to make an early assessment and intervention. And this is how you're going to save the child.
Thank you.
Thank you so much, Dr. Mediha, for answering these questions. Actually, the next question is a bit related to that. It's directed to Dr. Alia. So we spoke about different comorbidities and how they can manifest in individuals with ASD. The question is, how can these, like the presence of these comorbidities, affect the overall process of diagnosis and management?
How it affects diagnosis and management. So affect diagnosis in terms of maybe uncertainty or the need for further assessments. For example, a child with autism who has average IQ is different from one who has high or low IQ. And for this, we need a specific test. When it comes to management, same as all other conditions, we definitely need to map the child's weakness and strength because, for example, academic expectations are different. Approach to therapy is different, depends on the issue itself. We always say there are no two children with autism who are similar. So therapy is always targeted. There is no umbrella therapy, and it has to be targeted to the problem.
Yes. And this is perhaps one of the more common things that we keep reiterating until now that, as you said, autism is different in each and every individual that has ASD. The next question is on a similar note. Can some comorbidities manifest differently in individuals with ASD compared to someone who doesn't have ASD?
Possibly, yes. There could be so many examples for this. For example, let's say an anxious child with ASD may not display anxiety in a normal way or voice it or communicate it, unlike another child who's anxious but not on the spectrum and is able to verbalize and communicate their difficulties. So there could be many other examples, but it all goes back to the mapping of strength and weakness. It's not enough just giving a label and say this child has autism, because that doesn't describe a lot. It's only the start. There should be a very detailed report or assessment of their areas of strength and difficulties and what therapists need to work on. This is only the start of the journey, and the rest should be handled by the psychologists and therapy teams.
Thank you so much. Perhaps we can take one more question before moving on to our last speaker for the day. So this question is for both speakers. What is the link between Down syndrome and autism? Can you elaborate on how we can differentiate between Down syndrome and ASD?
Down syndrome children pretty much all have developmental delay, and their skills again are also variable. They have higher chance of having autism compared to children with no Down syndrome. So having Down syndrome is just a chromosomal disorder that makes them high risk or very likely to have developmental delay. But what type of delay? Is it just intellectual, or intellectual and autism, or intellectual and autism and ADHD? It could be any. So same as any child, we need to assess them the exact same way and find out what's the concern. There is some myths that children with Down syndrome all are very sociable, and obviously this is inaccurate. Yes, some are, but autism or children with Down syndrome are high risk for autism.
Thank you so much, Dr. Alia and Dr. Madiha, for sharing your experience with us. Please, you can also stay on the line because we will keep having questions, inshallah, after the last speaker. Dr. Zach, do you have any other questions, or should we move to?
We'll move to the next speaker now.
Inshallah. Okay. So last but not least, we have Dr. Lubna Hassan. Dr. Lubna is a Development Pediatric Senior Consultant Fellowship Program Director at HMC, Assistant Professor at Weill Cornell Medicine, Qatar, and works at Al Maha Center, Hamad Medical Corporation. Dr. Lubna, the stage is yours. If you can share your slide right now.
Dr. Lubna, are you with us? Okay, I think maybe
You can hear me?
Well, we can hear you now, Dr. Lubna, yes.
Assalamu
If you
alaikum.
can, Walaikum salam. Dr. Lubna, are you with us? So I think while we fix the audio issues with Dr. Lubna, we'll just take one more question from the audience. So Dr. Madiha, maybe we can direct this question to you. So the question is, how is Qatar handling people with autism? So those individuals who've been diagnosed with autism, is there special sort of like consideration in terms of the job market? So to make employment opportunities available for these individuals?
So
yeah.
in the older ages, and I think this is the question. So for job opportunities for universities, and we work closely with Dr. Mohammed Tulfat from Shafallah, and he said, and I had recently a patient who asked me the same question, and I had many patients actually, because they have gotten to the age of 18 and above. There's an application called Kawader. Kawader meaning jobs, I guess. So if they could go there, and if they're born in Qatar or Qataris, they would be able to assist them, definitely. That's and these are the higher functioning. They could find a spot. And also at Qatar University, they do have a section for learning disabilities. All right. So once they get accepted, the Qatar University, they modify their questions, and they have a special section for learning disabilities, and they could fall under that category. If that's the answer to the question.
I believe so, yes, thank you. Dr. Lubna, are you with us now? Sorry, are you with us now, Dr. Lubna? Okay, so I guess we'll continue taking questions from the audience. So I think this question was covered in last week's presentation, but we'll ask it again from your experience. Dr. Lubna, are you with us now? Okay, so it still seems like there's some audio issues there. So the question is regarding the trajectory for patients with autism. So do we? I think the question here is that as individuals they progress from being pediatric patients to adult patients, do we sometimes see that their symptoms they improve, and can we eventually see that there is almost individuals who they don't display any symptoms?
Very good question, actually. So I'm going to go back to the higher functioning. The higher functioning could actually, I heard that from a speaker in the US, they lose the diagnosis. I like that terminology. So the higher functioning, they learn the skills, and they are able to be enrolled in normal stream schools, and in their 20s and late teens, they might not look like what they did at the age of 3 or 2. But again, the lower functioning, it will always continue to struggle.
Okay. Thank you very much. And Dr. Halia, would you like to comment on that also?
I wanted to add that let's maybe grade it with severity. So severely affected children, whether they are have high IQ or low IQ, it's maybe less likely to lose the diagnosis or the label. Those with high IQ or average IQ are more likely to improve at a faster rate and develop, again, as Dr. Madiha said, coping skills, or issues may not manifest in public as it is with those with lower IQ. In general, those who were diagnosed early on and are mild on the spectrum may move on to another category. We call it social communication disorder. The difference between mild autism and social communication disorder is when they do have some social skills deficits and communication deficits, but they don't have the number 2 on that list, which is the repetitive behavior, the sensory deficits, the unusual language or robotic language. When they lose this, but they continue to have some deficits in social and communication skills, the label is changed from autism to social communication disorder. And I have to say, even within the pediatric population, this happens. Not very common, but I wouldn't say it's uncommon, where the child, because it's all a continuum, our social skills in general, it's a continuum. There is no straight demarcation, and there are some gray zones, and that gray zone between mild autism and social communication disorder. And yes, for mildly affected children, we always recommend reassessment every now and then. And yes, we have seen many whose label changed from mild autism to social communication disorder. I have to say, I haven't seen many where I would say the difficulties have gone, or it moved from mild autism to fully adequate, functional, normal social communication skills. At least within the pediatric population, it's uncommon. But moving from this category to the social communication, it's not uncommon.
Thank you so much. And just to follow up to that question, maybe could you touch on some of the sort of like contemporary strategies and techniques that you use within your practice, sort of to encourage the communication?
So I would say in general, and I will come back to communication, in general, early diagnosis is the key. Mm-hmm. The earlier the diagnosis, the better for the child. When diagnosis is made early, therapy started early, parents started to accept and understand the child's difficulties and work with the child to support them. I would say, I don't remember seeing a child who did not improve. By improve, I don't mean not having autism, but having less difficulties over time. Even the severely, profoundly affected children, with early diagnosis, right support, acceptance, parent support, they move to the better. Going back to your question about how to improve communication, this is obviously a whole world of techniques and strategies. Normally, the speech therapists guide parents through this. I would just say one thing, because there are so many strategies, but one I would say is play. Play is the key to improve communication. Parents may say, what is the connection between play and communication? Children learn through play. The more time they spend playing with people, not with screens, the better it is for their communication skills. And for this, parents need some guidance from professionals, mainly speech and language pathologists.
Thank you so much, Dr. Hadia. One of the future sessions that we have, I think in a couple of weeks' time, will be focusing on the role of the family members and the carers. So I'm glad that you've introduced that important point there. Thank you so much. Dr. Lubna, are you with us now?
Parents' role is
you can hear me now?
Yes, we can, Dr. Lubna. Thank you.
Okay. So I'm going to talk about the challenge of diagnosis and treating comorbidity in sorry, you can hear me now?
Yes, Dr. Lubna, we can hear you, yes.
Okay, sorry, I'm facing some technical problems with my computer, sorry. So I have no conflict of interest to declare. As my colleague said, autism spectrum is a neurodevelopmental behavioral disorder characterized by atypical social communication and repetitive pattern of behavior, interest, or activity. Individuals with autism often experience a variety of comorbidity and conditions that co-occur with other medical issues. Understanding this comorbidity and their treatment pattern is crucial for addressing the complex needs for autistic people or children, adults with autism. So in a population-based study in Sweden done, they found that over 50% of autistic people had 4 or more comorbid conditions. Recognizing comorbidity in children with autism can be challenging for many reasons. The first of that, the communication difficulty. As we are aware, children with autism often struggle with communication. They have limited verbal skills, especially at younger age, or they use alternative form of communication like picture exchange system. This difficulty in communication make it hard for them to express their symptom or discomfort related to other conditions. The other factor is the masking effect. The core symptom of the autism can sometimes mask or overshadow other healthcare issues. For example, a child who is fixating on a specific topic may not complain about physical pain or discomfort. The other things is the atypical presentation, some medical conditions that present differently in children with autism. For instance, anxiety might manifest in autistic people by hyperactive behavior or self-stimulatory action rather than the typical verbal expression of worry in general. Individual differences. Autistic people have wide range of individual differences, which means that treatment that work for one might not work for other. And from here comes the challenge in treating comorbidity on autistic people. The sensory sensitivity also, children with autism often have sensory sensitivity. Pain or discomfort related to a comorbid condition may be perceived differently by them. Overlap of symptoms. Certain symptoms are common both in autism and other conditions. For example, the sleep disturbance, feeding difficulty, or irritability can co-occur both in autism and other medical conditions. The other factor that play a role in the managing comorbidity in autistic people is the number of the research. Despite research being done in this field, still it's limited. That's why the healthcare provider face difficulty to develop effective treatment plan. The other things, the training and competency for the family, for the healthcare worker, also play a major role in improving the recognition, treatment of the comorbidity in autistic people. Diagnostic bias. The diagnostic bias can delay the identification of the comorbidity. For example, if the healthcare professional may sometimes attribute symptoms solely to autism without considering the other possible comorbid condition. The access of care also, such as long waiting time for appointment, and if we can say the few number of the provider who is specialized in treating autism and comorbid conditions also may contribute to this challenge. The other things I want to highlight also the stigma and misunderstanding. The stigma and misunderstanding by the families and our society also may stop parents seeking medical advice, getting proper assessment and proper diagnosis, whether for autism or the comorbid condition that's associated with autism. So this is mostly the common factors that contribute to this challenge in that recognizing and treating comorbidity. So to address this challenge, it is essential for the healthcare provider to have a comprehensive approach and develop a care plan for each child. This will happen by regular healthcare screening. So regular checkup should include assessment of common comorbidity that can help detect the issue early. Observation and collaboration. The healthcare professional should closely observe child during the regular check, collaborate with parents, and consider any change in the behavior or functioning is like an alarm to work more and evaluate more. Individualized assessment. Recognize that each child under the autism spectrum is unique. An individualized assessment considering the child's communication ability, sensory sensitivity, and behavioral pattern is also crucial. Multidisciplinary team. We need to consider collaborate with specialty from various fields to address the comorbidity in children with autism, such neurology, gastroenterology, psychiatry, and sleep medicine. So to develop a care plan, we need, as I said, each child to have a care plan. The care plan should focus on treatment, for example, the coexisting mental health and behavioral problem. the support needed for family and carer, necessary adjustment needed for this child, for example, by increasing structural and minimize unpredictability, putting goals for each child and try to achieve goals one by one. The care plan for autism disorder should seek to reduce symptoms that interfere with daily functioning and quality of life. So our target when we are forming a care plan for each child to improve his daily functioning and the quality of life. The treatment plan usually are tailored toward the individual ability and needs. Example of the treatment approach we are using, the first come the behavioral therapy. This is commonly used for autism management, focusing on social skill, communication, and behavioral modification. Example of the model that used by the psychology is the cognitive behavioral therapy. It is one of the psychology approach that focus on learning the connection between thought, feeling, and behavior. Pharmacotherapy also, there is a role for pharmacotherapy. Over half of ASD patients receiving some form of pharmacological treatment, but the specific medication vary widely, and even the response vary widely between child and child. The commonest medications that being used, for example, for ADHD, the stimulant and non-stimulant Strattera and methylphenidate, for aggression, risperidone, which is antipsychotic, and sleep disorder like melatonin. This is kind of example of medication we are prescribing for children to support them and to help them to function better. The aim of the treatment, treating co-occur symptoms that can help individual with autism function better. Combination of therapy, and which is frequently we are using behavioral therapy and pharmacotherapy are required to achieve the optimum result. Therapy switch flexibility is critical when developing treatment plan to address the changing need for autistic individual during counseling and mental health problem. So there is nothing, so there is no one model of care that lasts for long. Each visit we need to reassess, may work now, may not work next in the coming years or coming. So that's why every visit we need to do comprehensive assessment to address any changes in the behavior, medication side effect. So we need to be flexible in our management. This is a retrospective cohort study done in US, summarizing all what I said. It is done for newly diagnosed adult children and adolescents with autism spectrum disorder. They found that the common comorbidity is attention deficit and mood disorder. The treatment pattern usually either behavioral therapy, pharmacotherapy, or combination of therapy. They found that the individualized newly diagnosed with ASD, a comprehensive approach that consider both comorbidity and tailored treatment is essential for improving the outcome. So despite all this challenge, individual with autism and comorbid condition can lead fulfilling life with proper support and treatment. Early detection and intervention can significantly improve the overall well-being of children with autism and reduce the impact of comorbid conditions. Okay, thank you.
Thank you so much, Dr. Lubna. This was such an insightful presentation. Indeed, there are so many challenges that are standing between us healthcare providers and basically providing optimum care for individuals with ASD. You talked as part of your presentation about behavioral therapy, and we have received some questions in relation to that. Perhaps that's the first thing people think about when we talk about ASD. But then you also discussed the importance of a multidisciplinary approach to treatment and therapy for individuals with ASD. Can you perhaps elaborate briefly about the efforts made in Qatar to support this approach?
Do you mean for the therapy in general or the behavioral therapy only?
Therapy in general, like multidisciplinary treatment.
Okay, I will talk for example, in Hamad, our clinic for autism, it's not like an individualized clinic, it's a multidisciplinary clinic. Usually there will be psychologists, there will be speech pathologists, because to address the needs of the children, to provide them with the family with proper support. That's why we are implementing a multidisciplinary approach for managing and assessing children with autism spectrum disorder, and this is well known and kind of care for children with autism spectrum disorder. So this is what we are doing, and we found it is very effective, and the family is satisfied. They get a proper support by the psychologist and by the staff and the doctors. So there is that's it. I guess I answered the question.
Yes, thank you so much. And just to reiterate what Dr. Zach said at the beginning of this session, inshallah, next session we will be talking about multidisciplinary care, inshallah, and we will dive deeper into this topic. The next question is related to masking effect. You mentioned this as one of the challenges that are related to diagnosis of ASD and comorbidities of ASD. So can you perhaps talk more about the masking effect? What is it, and how does it look like, and how can you look for it?
Okay. As I said, in the masking effect, because the children, the core symptom of the autism can sometimes mask or overshadow other health issue. For example, a child who is fixating on a specific topic or his fixating interest, he may not pay attention more to the physical pain or the discomfort, and he have difficulty to express that. This is one of the major cause that he cannot tell that he has the pain in some, for example, in some area, because he is ignoring this and fixating in some topics or some interest other than the pain or the discomfort that he had. So this is what I mean by masking effect. The dominant of the autism core feature from fixating interest and delaying in communication that can affect his ability to express the other worry or the other problem that he is facing. This is what we mean by masking effect.
Thank you so much for
By the
answering
way,
this question.
they found that most of the autistic children, that's who is, if we can say that, cognitively normal, they learn when they get older, they learn how to mask the autism behavior, and they function very well with proper therapy and with proper support. They learn how to mask their worrying, their behavior, and function very well in the future.
Thank you so much for elaborating on that. If that's the case, then perhaps this is a good segue to our next question. What are some signs that parents or healthcare providers should look out for that could indicate the presence of common comorbidities in individuals with ASD?
Okay, the trigger factor, for example, the behavior. Usually, if the parents find that the child is not in his usual, and there is any new behavior that happens, so that means we need like alarm that there is something going on. Okay, and they need to seek medical advice. Okay, could be even not. It could be this behavior reflecting physical problem on their, like ear infection, for example, abdominal pain, constipation. So mainly, if the parents notice any new behavior in the children that not present before, that need to alarm them that they need to seek medical advice, to dig on more on that, to do proper assessment for the child, so we can detect things early.
Thank you so much, Dr. Lubna. Indeed, this This was such an interesting topic. Dr. Zach, do we have time for more questions? We have so many more questions from the audience.
Let's go with a couple more questions, please, Dr. Shahad.
Okay. This question is in relation to ADHD, and it's directed to any of the speakers today. Can difficulties with learning be the first warning signs of ADHD in individuals with autism? If not, what are the other signs that we can look for?
Happy to take this if you want me to.
Go ahead, please.
Yeah. So autism itself can cause issues with learning, in addition to possible intellectual delay, or they could also have ADHD. If they already have autism and struggling with learning, parents may not think of additional comorbidities because they will assume it's their autism. But I think ongoing assessment and follow-up are important because, yes, there may be some additional problems. For example, they may have average intelligence or above average intelligence and autism, but they're failing completely academically. And the professional in this case will assess the child and see, does that match their level of autism? Does it match their level of academic difficulties? Or there may be some additional problems such as ADHD, or could be phobia, could be social anxiety, could be sensory problems in school. It's too loud, they cannot focus, or they don't like, it could be anything, I mean, when it comes to sensory. So I think assessment is the key, and ongoing assessment and follow-up should happen irrespective.
Well said, Dr. Alia. Thank you so much.
There is a question here about the frequency of follow-up and monitoring. I guess that would be catered according to the patient and to you know, the frequency that you're noticing any changes. But could you elaborate a little bit more on that? I mean, for a diagnosed individual, how frequently would you be assessing them? Sorry, you're muted.
Yeah, so yes, as you rightly said, it depends. So in their early years, I would suggest regular assessment. It can vary. It could be every 6 months, every 9 months, every 12 months. So anything between 6 to 12 months. Once they're settled in a school where everybody think it's the right one for that child, that by this I mean the parents, the child is happy, professionals feel this school serves their needs, and if the child is making good progress, there are no additional ongoing major issues. Sometimes, and again, that comes to the clinician's practice. It can vary between professionals. But personally, sometimes I leave it to parents to contact me when they need to. And when demand changes, for example, they were in primary school, everything's going beautifully fine. They have all therapy in place. Parents are well trained. They know exactly what to do. Child is making good progress, happy in school. Demand changes over time. They may come to secondary school and behavior deteriorates, for example. This is a sign that they need to be assessed again. There is no harm from ongoing regular assessments. In case there've been assessment or follow-up is as and when needed. When there are changes, this is a sign that they need to be assessed again. So basically, there are no hard and fast rules, but young age, better being seen regularly, older age, either regularly or depends on the needs. But there should always be a connection with a professional that they can go back to when needed.
Okay, I agree with Dr. Alia. but I will divide it in another way. For example, for a physician, upon diagnosis, we can see them like regularly because the family need more support, more understanding. So maybe every 6 months, for example. But therapy-wise, it should be the visit will be more frequent, like with the multidisciplinary team, with the speech, with occupation, with the psychologist. Their visit will be initially more frequent than the physician. But for us, we are seeing upon diagnosis like every 6 months. Then when the child is grow up, the family have more understanding of the spectrum and the needs of the child. Then the follow-up will be like every 8 months or 9 months. And when the child is settled in the school, it can be for the first couple of years, it will be annual till we feel that the family is confident managing the child and have better understanding about the autism and how to control the child behavior, to support the good behavior. Then we can stop following them unless they need anything show up later on. Then they can get a new referral. Then we can do another assessment to see what's going on with the child if new behavior show up.
I will also add one point to what Dr. Lubna already very nicely described, that what is the role of the physician. So the physician, or like us, like myself, Dr. Lubna, Dr. Madiha, our role is mostly diagnostic, in addition to, for example, investigations, looking for the reason of their delay, blood tests, genetic tests, and medications when needed, when appropriate. So that's, and follow up and looking for comorbidities as time goes on, and making sort of a plan with the family. But then the regular therapy, as Dr. Lubna said, is by psychologists and therapists. So I always explain to parents in clinic what is my role, because when I diagnose and they say, why don't you see us in 2 months? I will reiterate and say my role is mostly diagnostic and the other things I just mentioned. And in 2 months, there may not be major changes, but that doesn't mean I cannot see them or talk to them if there is a reason.
Thank you so much. Thank you so much. I know that there are a few more questions in the chat, and we have saved those questions, and hopefully we will cover them in future sessions, but we have run out of time for today. I want to give a big thank you again to our amazing speakers, Dr. Lubna, Dr. Madiha, Dr. Alia. Thank you so much for giving up your time and sharing your insights. It's been really, really fruitful conversations. Thank you so much. And we would like to invite you back to the future sessions and join the panel and contribute towards the discussion. So thank you again. And I'd also like to say thank you to our participants for a lively discussion, sharing your questions and your comments in the chat. And we look forward to inviting you back next week, where the topic will be based on evidence-based multidisciplinary care. So thank you so much for joining us this afternoon, and we look forward to seeing you next week. Thank you again.
Thank you.
Thank you, everyone.